Go ahead and get started. So, hello everybody, happy Wednesday. Welcome to the Convergence Health Workforce Wellbeing and Violence Prevention Improvement Series. So today is session 4, June 12, 2024, and we'll be chatting about our topic area today is From Weariness to Wellness, our journey in building a robust peer support program. So before I go ahead and introduce our speaker for today, I'm going to go over a little bit of housekeeping. So for our webinar, we'll keep everybody muted. We encourage you to use the chat to ask questions throughout, but our speaker will be answering questions at the end. We'll have a Q&A session. This is me to introduce myself. My name's Helen Craigie, and I'm hosting this series. I've had about 10 years in quality improvement and patient safety work. My background is in bioethics, and I am just honored to be hosting this series with all of you. Go to the next slide for a little bit of context. And I know I've shared this already. This is some findings from an American Nurses Foundation survey of more than 7,400 nurses in the US. This was about a year ago, so May 2023. And as you can see, workforce well-being and violence prevention is a growing challenge in our healthcare field. So as far as the intent to leave and nurse turnover, that remains high. So 20% of people responding noted that it indicated changing positions in the last 6 months. So that's 20% of our workforce has changed positions in the last 6 months, and 40%, almost 40% were indicating that they were likely to leave their current position in the next 6 months. So 41% for direct care nurses. So that remains high. Burnout is a major challenge. Almost 60% of nurses reported experiencing burnout, including emotional exhaustion. And 64% say they feel a great deal of distress because of their job. In mental health, among nurses and those responding, 40% of nurses surveyed felt poor control over their workload and said their day-to-day work is hectic or intense. 2/3 of nurses said that were suffering from mental anguish or toxic emotions are either not seeking or receiving mental health support. So this is a major issue. And 56% said there's a stigma as healthcare providers associated with receiving mental health care. So as you can see, this is a major challenge for our healthcare workforce and an important topic for us to be exploring. On the next slide, just a reminder of our broad approach to this topic. We're still in a learning stage as Convergence Health. And so this is our 4th session where we're hearing from Karen Garvey from Parkland Health in Texas. And I am going to introduce Karen on our next slide here. So delighted to introduce our speaker for today, Karen Garvey. She's the Vice President, Safety and Clinical Risk Management Chair, promoting a safe environment committee. So she's an executive sponsor of Sparks Peer Support Program at Parkland Health in Dallas, Texas. And so Karen, before I hand it over to you, we've been asking our speakers to introduce themselves, answering the questions of why is this topic so important to you personally? Why is it important to all of us here today? And why is it important for us in the context of today's environment and healthcare? So Karen, I'm delighted to hand it over to you, Karen.
Great, thanks so much, and thanks for attending, and thanks for allowing me to be here today. I'm super excited. I've been talking about this issue for a long time. So going back to me, I've been at Parkland for 10 years actually this week, and have been working on workforce safety, violence, and wellness ever since I came here. But it had also been something that I had tapped into in my previous job prior to coming to Parkland. I've been busy working with a team. I'm just the vocal point. We work together, and you'll see the work, the amount of work and the teamwork that has allowed us to do this. This is important to me because well-being is about being our best self, really taking care of ourselves to do the best work that we can. Not only for patients, but for one another. And realizing that sometimes our peers may need some extra support. They're having a bad day. Ironically, I was listening to a colleague yesterday who was venting about some things and took the time on my way home to actually call him and say, hey, are you, just tapping in just to make sure that you're okay. Sometimes things are more challenging, but just know that there's people that are here that can lend an ear or to try to help you navigate. Why is this topic important for all of us? There's been so many social challenges and issues that emerged during and after the pandemic. There's been pretty much a blurring of work-life balance. We're trying to manage some of the social determinants, not only of our patients, but also our employees too, and getting them to be not only physically, but mentally and financially healthy in their environments. Certainly, a healthy workforce can improve the bottom line. There's less absenteeism, less of that presenteeism that they're here, but they're really not connecting the dots. From a patient safety point of view, there's less errors that can happen. And if you really think about it, if somebody is healthy and they come upon a hiccup where they're not doing well, it may also shorten the recovery time, knowing that they've had some stability in their lifetime, and that helps to get towards the resilience component. And certainly, if we don't take care of our workforce, they will not take care of us doing the job that's expected of them. I was in a conversation last fall with some of the folks from the federal level, and they had asked, some questions about, what we should be doing differently. And, one of the things that I had mentioned is that for many of us, we have these patient safety indicators that we're being managed by, and we have to really have some goals towards them, but they're really patient focused. And so my suggestion to them was maybe we call them safety indicators and have one arm for patients and one arm for our workforce. So I'm not really sure if that's going to go forward or not, but that's something that we've been trying to strive for in our own organization. So why now? It's not just now. This has been for a while, but I think it really emerged showing the need for well-being, again, since the pandemic, realizing that some folks may be more challenged in coping mechanisms or having lost some of their normal coping skills. I mean, we've seen it not just within what we do in healthcare. We've seen it in the airline industry. We've seen it in road rage. I've witnessed it in the grocery stores. People's fuses are just really, really short. So how do we manage or approach knowing those instances? So this is why it's important to me. And I'm really excited to be here to talk about what our journey has been. And so a little bit about Parkland Health. It was founded in 1894. It has 882 beds, although I will tell you that we are over census almost every day. We are the safety net facility for Dallas County, large homeless and behavioral health population. We are the teaching facility for the UT Southwestern Medical School residents. We we also take care of the medical care in the county jail, which houses anywhere from 6 to 7,000 inmates. So that is a city in itself. We have a burn unit, we have a large neonatal intensive care unit, and a large maternity unit, I think being the second or third busiest maternity unit, but it's been cited as being the busiest ED in the nation prior to COVID and certainly after COVID, with about 250,000 visits per year. So we are busy, and we're seeing a lot. But when it comes down to looking at well-being and peer support in our organization, when I came here in 2014, we were under a corporate integrity agreement, so under the scrutiny of the federal government. And I came here knowing I had worked in another organization under a corporate integrity agreement. So I thought that, I could do this. But it was definitely different. A lot of scrutiny, a lot of fear going on in the organization, but there were some folks that I had, been able to actually talk with to say, hey, you know what? Is anybody interested in putting a peer support program together? There was some dialogue, and I had done this a little bit in my previous job in creating a Code Lavender. So, we started a conversation, a few interested parties. There were 4 of us. We all had an idea. The one was in behavioral health, one was a chaplain, one was in trauma psychology, and then it was me who worked in patient safety and clinical risk. So we collaborated behind the scenes. We thought, how can we really do this? We identified an opportunity to actually put together a grant proposal to our Parkland Foundation, which grants monies for different things within the organization. And we took the courage, even though we were under such duress and pressure to perform under our corporate integrity agreement, we still found time, pulled things out of our back pocket, and really went to move forward. And then we took our creative knowledge. Every one of us, of the four that I mentioned, came from different walks of life, had different specialties, but we all collaborated together. And then we were able to create, we found an opportunity ahead of us. So this is going to kind of go over the beginning of our peer support program. I know it looks pretty primitive, but it does kind of give you a better idea. So back in right after Christmas in 2015, we had some terrible tornadoes. We've had some more recently too, but it really wiped out some of our employees' houses. Some people actually expired there. Some of their cars were taken off the highway, or they went over. And then we also had some serious Dallas police shootings where those trauma victims actually came in here, and there was a lot of turmoil going on in the organization at that point in time. And I remember being here that night when all of that was going on. So we have had some of our own opportunities within the Dallas community. And then, having done this in my previous job, I took some of the pearls of wisdom and actually worked as we did our culture of safety survey, which we used the AHRQ at that point in time, and actually worked to get some questions in. And we formulated them to see, do we have opportunity? Do we not? And so we actually utilized the questions that are on the screen, and when we surveyed in 2017 and 2019, and we found that yes, there was a need. They knew of, our employees were telling us that they knew of people that were harmed, that were in distress, and they felt that they would need something. So we took this information forward as part of our justification in moving towards the Parkland proposal. So we did a proposal. We got awarded $37,000, which I didn't really realize was a lot of money at that point in time when they were giving out, $5,000 here, 10 grand there. So $37,000, we took that and we turned it into reaching out to Johns Hopkins, where we had a contact. And knowing that Johns Hopkins had the RISE program, Resilience in Stressful Events, we worked with them in the Maryland Patient Safety Institute to actually start to formulate our program and at least get some ideas as to where we wanted to go. And so we got our check. That's the initial four of us that started. Three of the four of us are still here. The lady on the right is actually Beth. She's from the foundation. She is still here. And then we were actually able to have our first class, which you see on the right-hand side. It is an all day. It's a theory, but it's also role playing. It has to be interactive. And so we actually developed an executive steering committee, which actually included our human resources, a rep from human resources. We outlined and with legal as to what we were going to accept for the encounters that we would actually reach out for. And then also we were going to be passive in that we would start to put our information out there, but we weren't going to be deliberately reaching out to people when things were happening. We have two peer supporters on call 24/7, 365 with a higher level mentor who's also available should we need it. But it kind of goes to show with that very first class, they're coming from all different roles: nursing, physicians, lab, the chaplains, IT, nursing administration, data. They're all from different walks of life, and we continue to monitor the people that we have across our organization. So we were really, really proud of this initial group. And then we actually, we went live, we had a second training, and we continued to have people. Even somebody on Monday said, "Hey, Karen, you came and talked to our staff meeting a while ago. I want to know how I can become a Spark." So this has continued to proliferate, and we certainly have goals of what we have every year as to how do we continue to propel this program. So we were very fortunate to actually get this up and running in February of 2019. This is our mission statement, and this was some of the documents that we pushed out because we wanted the people to know that we were confidential. We don't write down names. We wanted to be able to be there, and we focused at that point in time on the second victim, and which I know has had some people are kind of, they frown regarding the wording, but realizing that we know that people are suffering in silence when there are things that are happening, when you have adverse outcomes, whether the individual is at fault or not. So we started to put this information out there, but we also held a kind of like a grand rounds to see if this was going to be something that was going to be supported in the organization. We took physician, operation, and nursing leaders to an offsite and had a dialogue about it. And they were like, yep, we need it. Let's go with it. So we moved forward. And we also structured it in a 3-tier process, meaning that the peer supporters are only about the psychological first aid. And so when you talk about Sparks, Sparks stands for Supporting Parkland Staff. And that was actually an acronym that was identified by somebody on our team. So our job is to provide psychological first aid to get folks back to an equilibrium. What were they doing before that event, and trying to get them back to be stabilized? Getting them back to a well-being. And like I said, there are peer supporters that are on call 24/7, 365, and they rotate on a weekly basis. The second part of that is we do have a higher level of mentors and trauma psychologists and licensed behavioral health clinicians that do work with us too. And then the third level is certainly the professional help, and we have had to move employees into that space. We have identified a process where we can keep them confidential when they are in major distress, and getting them to a space within the emergency department in a private area where they can be treated and still remain confidential. So, and then we utilize definitely our employee assistance program, our spiritual care of chaplains. As I mentioned previously, when we have employee related incidences and deaths that happen, we all collaborate together. Some people are working with the family, some people are working with the staff, some people are working with other things. So we are all doing this together. And so the next slide goes into, we had a retreat. We had a 1-year retreat annual. We were so happy about it that we were able to get through our first year. We talked about what went well, what we needed opportunities, and we certainly had some guest speakers. And so certainly if you look at the date of February 28th, 2020, what came just a few weeks after that? And I'll tell you that, we have, like I said, this is a huge group. It's one of the biggest, I think, in the country. And we all do a really good job about taking care of one another as well. And many of these folks, I think about 24 of them, if they haven't left the organization, they're still highly engaged in this, through the 5-year mark that we just had our anniversary in February. So again, then it come down to COVID, and yes, this impacted all of us. And we were so fortunate to have 1 year under our belt to kind of figure out what was going well, where we needed to pivot. But certainly during COVID, and knowing that people really trusted us with calling and having these encounters with our supporters, we had to pivot again. We had leadership call on us to say, could we actually set up some office hours during COVID? Could we actually were checking on our own peer supporters, because many of them had to relinquish their peer support responsibilities because of their day job, and knowing that people were ill, or they were furloughed, or they were leaving and were short-staffed, we couldn't ask them to do anything more than what they were able to do. But we did do role play. We did do office hours. We just did check-ins on them as they were checking on other people. And even for me, being a leader in this area, I was in scrubs. I was here every day. I was still rounding, and realizing that made a huge difference with some of the staff just to know that we were there. In addition, this is what I was saying. I was sitting on an ashram board at the time. And I can remember having a huge sigh of relief about the violence, even though we were having 60, 70 reported events a month prior to COVID. And then those numbers really sank. And I was like, thank goodness, for a minute. But it was 2 months. And then they started to really escalate high. If you go back to that time, patients were extremely ill. We were not allowing visitors in. And so it was really a different point in time. But when things started to kind of stabilize a little bit and things changed, people were becoming frustrated. And it was not only just the escalation of family members and patients because they couldn't see family members, but it was also our staff who were escalating because of the anxiety of we didn't know. So I had asked my colleagues on the Ashland board, are you guys seeing this escalation of violence, not only in numbers, but in higher levels of aggression? And they agreed with me. They said, we don't know where it's coming from. And so you know, certainly as the airline industry opened back up, you started to hear about this and it was being advertised. And I'm thinking, okay, we are still dealing with this internally, but yet there's no public face of information that's going on in healthcare. Why not? So we realized that we had some opportunity, and so we worked on our platform and continuing to pivot. One of the things that Helen had talked about in the very beginning when the title was on here, and this happened in 2021, was we had submitted, which I totally forgot about prior to COVID, about being a trusted entity, a trusted program. And there were about 50 entries that went in, and we ended up winning one of them for Sparks. And people do trust us. I mean, certainly when we launched the program, my philosophy was, even though I work in the quality and safety area, was I don't care where this lives. It just needs to live and it needs to be protected. Ironically, because we have a really strong high regard in the organization for confidentiality, it has stayed in this area. I know in some other organizations, it may be that they live in HR, the spiritual care area or other locations, but it has continued to live in here. And so this was something that we were really proud of, to realize that, you know what, out of all these applications, we were one of them that came out knowing that we're a trusting entity, and people continue to still trust us. So I wanted to make sure that I mentioned that. So when we go into peer support training, it's pretty rigorous. Again, it's didactic. They learn about trauma. We talk about trauma-informed care more recently, which is, you know, it's circulating out there, as to how realizing that there is a universal protocol for trauma, and you have to assume that everybody has had trauma in their life. And so you approach individuals thinking that something may trigger them, although you don't know what that is because it's pretty much invisible to everyone. But we continue to have peer support training, and people are really, really excited to be part of our team. We even hold one in the correctional health setting, and these are all correctional health facility folks, because what you see in the jail with the inmates, and certainly sometimes, unfortunately, the sheriff's office, is different than what you would experience in the clinic settings, as well as in the hospital setting. So we have, again, folks across all areas of the organization. We have champions in the ambulatory clinic. And also that can be the go-tos, because if we're housed at the hospital, some of our clinics are peppered all around Dallas County, way north, way south, and they need immediate access. And our goal is to have a peer supporter within every one of our clinic settings or our business office settings. We're not 100% there yet, but we've continued to improve that over the 5 years. In addition, this is one of our strategic priorities. So we've since merged our cultural safety survey with our employee engagement survey, and have moved into the Press Ganey model. And so when you look at some of the questions that align with this area, this actually came out as being a staff and provider engagement opportunity. The violence has been something that has been worked on since I started here, but realizing that it's now a strategic priority. And certainly as we've done enterprise risk surveys as well, risk assessments, since 2019, violence has come up in the top 10 elements of risk to the organization. So there's plenty of opportunity when you survey people and what we're doing, but this has become something that I've become a work stream leader, co-leader in with one of my physician colleagues. And so this was something that somebody had sent me last year, and it says, is rudeness here to stay? And the quote, the trend has hit healthcare hard. Hospitals and health systems nationwide have reported an uptick of disrespectful, discriminatory, or violent behaviors from patients since the pandemic. Nearly 24% of physicians reported experience workplace mistreatment in 2020, including verbal mistreatment or abuse, according to a study published in JAMA Open Network. So it's something that if you're thinking that it's happening, it likely is. But we also had to teach people and educate people on what violence and verbal assaults were, because people they just thought that this is how people talk to us. what's acceptable and what is not are two different things. And so when you look at what came out in 2022, the Joint Commission came out first with their workplace violence standards and elements of performance, of which there's 5 standards, which cover environment of care for the most part, human resources, and leadership. And the leadership component is comprised of a culture of reporting, and providing that information back to the staff and trending that data. HR is about the education and training. Where do you require education and training? What do you require? Is it an online, a click-through PowerPoint presentation? Is it de-escalation training? And do you have high-risk areas? In our organization, high-risk areas are typically the ED and behavioral health. We do see the most. We have an inpatient elopement unit, 17 med secure, which also sees a higher number of them. But we've seen these pop up in the OB area. And if you look at what you see on a national scale, ED, behavioral health, OB, and community health are the top 4. We do see the same levels in OB, ED, and psych, but within this last year, we've mirrored some of the national data where we've seen a huge spike in medical surgical units because of the coexisting behavioral health conditions along with medical surgical conditions that the staff are having to deal with that may not be necessarily as equipped as they would be in the ED and behavioral health, where it is a requirement to take full-on de-escalation training. Although many of the leaders in the behavioral health or the med-surg areas are encouraging their staff to take them, and they do it on work time that is paid for as well. But definitely the Joint Commission has come out. I know that when they came here in early 2022, they didn't ask one thing about the workplace violence. I know when we're going to be resurveyed here shortly, they're asking a lot, but we're prepared for them. We've got a big syllabus of what to be able to present to them. And then, 11 months later in November, CMS sent their information out. And I assured our executive staff that we're on board. We've got things going on to make sure that we're in line with the expectations. So there is a lot that's happening both at the national and at the accreditation level. But in addition, Texas has, there was a bill that went out in, I think 2017 or 2018, a proposed bill, and I think it was labeled House Bill 136 or 132. And having been a leader in the workforce safety environment here at Parkland, I convened a group, a small group, facilities, environmental safety, outpatient areas, to really start to look at the bill and what the elements and the requirements were. Well, I didn't realize that the bill was on the docket, off the docket, on the docket, off the docket. Well, but we continue to work towards all the elements of the bill and get them in place. One of them, which was a required workplace violence plan that is proposed to your leadership with we put proposed goals on there. But it's about looking at who's on your, you have to have a committee, and who's on the committee has to be a practicing nurse and a practicing physician, at least for the most current bill, which is 240 today. Reporting of events, reporting of information to the board, reviewing of incident reports, trending them, investigating them, and then certainly having a plan. And then certainly as this bill went forward, it became a Senate bill, and then the Senate bill, the correlating Senate bill for the criminal penalties that were increased from a misdemeanor to a 3rd-degree felony for hitting or hurting any healthcare worker and not just a clinician. So these were things that we had continued to work on, although Senate Bill 840 came more recently, and it was after the very unfortunate incident at Texas, the Methodist shooting in Dallas a couple of years ago. So that became as a result of that case in itself. But we realized that we were doing a lot. Texas, the Texas Workforce Studies Group actually puts out grants, and I had submitted for a couple of grants. Their maximum amount was $650,000. In 1 year, I received half of that money, and turned it into personal alarms. We created some lavender carts to be able to push out to the staff, and we did that. We did utilize that money for purpose. We actually took and created a curriculum and went to some of the local nursing schools, because if we don't teach them what's going on in our organization. Again, it's a fine dance and it's a very delicate communication. It's more or less to arm them with information, not to scare them. But it is, that's continued to propel itself, realizing that we need to teach all allied health individuals, not just nurses, but physicians as well, that this is a reality when you get into some organizations, and to be aware, to, what resources do you have? So moving forward, these were the elements of the Senate bill that went forward. And so we continued to work on this. We present this in our monthly Promoting a Safe Environment, which is also known as our Workplace Violence Committee. That's what we termed it because we wanted to have a positive spin on it. And then what you have on the right is actually our 4th workplace violence plan, which was approved by our board and our executive team. And we continue to work towards those goal attainments. But have also brought forth a multidisciplinary group. In fact, we were just talking, we have a meeting tomorrow of identifying who's going to work with us on revising the plan for 2025 along with those goals. Because we want people from all of the areas, the community health setting, the correctional health setting, and the ambulatory, as well as the hospital, but all different roles too, to help us with goals that make sense for our organization. And so we testified last year in March as it was going to committee in Austin. And Donna Hale, Representative Howard is actually in the middle here. She's a nurse, and she was injured by a patient. And Stephanie here, the leader of the committee, is actually a nurse who had her arm broken. This guy here is an anesthesiologist, and this lady was new to the committee. On the Public Health Committee, she was a prosecutor. And when she was listening to what we were testifying about, she was horrified that this happened in healthcare. She stood up and said, "You've got to be kidding me. This goes on." So it led me to believe that we continue to work so hard behind the closed doors, but this has not been in public view until it's been seen in post-pandemic. I've always called it the epidemic before the pandemic and behind closed doors. So this is now out in public view. But when we actually testified, I testified on the stuff that we were doing, the monies the grant monies that we had used from the Texas Workforce Studies and what they were utilized for, and being a safety net facility where we don't have any funds, and I don't have a budget for this. We continue to kind of beg, borrow, and steal from other areas. But we were highlighted as the only healthcare organization in the state of Texas to actually have every element of the bill in place before the bill was signed into law. So that was good for us. So now fast forward, we realized that violence is not just a one-day event. And so we actually publish our statistics for every weekday on the number of violence events that actually are reported overnight. And we publish it in our executive huddle so that people have an understanding of this and how it's impacting the staff. So when you look at our workplace violence events, you can see, and I just pulled our May data out, we do see a fair number of them. We did transition to a new risk management information system in November, and we actually built the icon for the vendor because they did not have one. They actually embedded violence kind of on the back end of every single event type, which didn't work when you have to report data to the Joint Commission and to the state and to potentially CMS if they come in. So we had worked really hard in our last system and built a lot of information on the back end that we wanted to be able to extract out. So when you look at November forward, you do see primary and secondary items, one in blue and one in gray. And so when you look at the blue, we realized in our last event reporting system, and we're not an OSHA reporting facility. So we have different definitions. We use physical assault, verbal assault, disruptive behavior, and destruction of property. I know that OSHA has their 4 categories. But when we realize if a patient is being physically violent, they're likely throwing and destroying things, are likely yelling too. We were only able to capture one of those events. So as of November, we've been able to capture a primary, but also highlight secondary events as well. So that's why you see the gray bars. Because if there is a sexual innuendo, racial innuendo, those kind of things, we want to be able to capture those because those are still things that are harming our employees, and it's not just one categorization. If you look at the trending on the upper left-hand side, we will definitely surpass what we have reported in fiscal year 23. But I will tell you, it's because of a lot of the hard work that our team is doing too. And so when we look at it, we have a tiered process for managing events. So these come into our reporting system. I've been able to hire a manager sitting on the IHI committee. I would listen to see what kind of structure other folks do. And I created a position for a manager in this space, which I'm realizing now is not necessarily enough. But just before in late 2022, we were also given the permissions to manage some of these behaviors by doing full investigations, almost like a cause analysis or root cause on these cases where there's higher levels of severity or high levels of aggression. And if there's repeat behaviors that are going on, we are able to, going through our very rigorous process, is to administratively discharge them from a safety net facility. And so this is kind of the process that we go through. So we do behavioral warning letters, and you'll see on the next slide how many of these we have in the queue. But we've also been able to realize, as we reviewed all the behavior warning letters from the cases from 2023, of which there were 109, 95% of those individuals, patients, have not had another incident. So it is working where they are reforming the behavior. We provide the behavioral expectations. We also provide them what they were reported doing or saying in letters that go out to them certified. And if they escalate up the process to the point of, we may have a full-blown meeting with some dedicated folks that actually goes up then to our chief of staff or our chief medical officer to either sign off on if we're going to terminate or not, or push back. Because sometimes we realize, hey, our behaviors are not what they should be. And sometimes our systems are broken and our patients are caught in the middle, that we need to fix the system to prevent them from escalating. So we do advisories where the individuals let us know that they want to take a patient forward to correct their behavior and what they're doing. But we also expect local leaders and physicians to be able to help to have this dialogue with the patients. It's not just us. And then we have terminated case reviews, which are kind of like our root cause, where we've evolved over time, and we actually bring in trauma psychology to look at the trauma history. And so when you look at some of the traumas that these patients have gone through, sometimes we unknowingly induce more trauma to escalate them. And so there's been cases where they've been pushed in to see if we can discharge them. And the answer has been no, we need to fix our systems or realize that we need to schedule them differently or have them interface with other individuals in situations so that we don't trigger them. And then it goes up to a termination process that goes to the chief medical officer. Then we do another annual review to make sure that we still need to validate that termination should stay current, because we don't want to profile people either. We realize that people's lives have changed, and we want to be able to manage accordingly. And so this is the progression of our case reviews. When you look at the yellow, it's actually the letters that we are writing on a monthly basis. And so and then the warning letters, and again, the number of folks that have been terminated over time. So it is a process, and it's a lot of work. And I have an awesome team that helps us do this. And so the next is how we also manage as an organization for violence in general. This is not just in my area from the human component. It's working with our environment of care folks who look at the physical security. So we work together hand in hand, arm in arm, from a collaborative process, but the board is very, very engaged in this. They're very concerned about this and what it's doing to impact our staff. And they're very supportive. So we do report out to them twice a year or more often as necessary. They wanted to see they want to know about the bills and the goals that we have, so we provide that information to them. But it is pretty wide in having focused areas as well. When it comes to the correctional health setting, they have unique violent episodes that we want to work with them on, as well as we've pulled in our APPs because they're peppered among many different service lines, and they're not necessarily getting the whole scope and the information. So we continue to work collaboratively across all our organization. In addition, we just had our fourth or our 2024 education. We do about one per year. We've actually created our own training guide that we had Johns Hopkins come in and do a couple of courses with us, and then we built our own. And it continues to evolve over time too. But it just goes to show the number of folks who continue to be interested in this. And it's amazing. We have about 66 peer supporters from across the health system. And again, we wouldn't be able to be successful without all of what they do. So trends by year. So we do track our data. And so, again, we've had 5 years of data, and initially people were calling us. I think our initial call was about an HR issue. I said, no, that goes to HR. It doesn't come to us. We need to keep them in their lane and us in our lane. And so when we do encounters, we don't write down names. We don't really write down information, but we do put information into an encounter form, because we want to know if they were individuals who came to us by themselves, if they were referred by their manager or someone else. Times of day, days of week, we calculate all of that kind of stuff. But we really found that in the beginning, it was just work stress in general, things that people were dealing with, and then COVID hit, and then COVID became a major issue that people were reaching out for. And so when we talk about an encounter, it is a call to, hey, Karen's on call. It's an interaction, but we also realize that there's encounters where we may be talking to a whole in a staff meeting of 30 people. So we also count the contacts. So we would have one encounter, 30 contacts for that staff meeting. So we've learned to kind of like manage our data a little bit more eloquently so that we can really see what these trends are. But if you look at what's been happening in the last 2 years, violence has been the thing that they've been coming to us on. And so we do feed this information back. It's another data point to show that there's definitely a need for this in our organization. It doesn't usurp EAP. They are partners with us. It doesn't usurp the spiritual care area or our employee health or occupational health. We all are working together to make sure that we're sharing data too. And in addition, back in 2022, in order for us to calculate why people were maybe off work for violence, we were charging folks who were involved in these events PTO to take time off work. And I thought that's not right. You wouldn't do that for a patient or an individual who fell or strained their back. So we actually created a time and attendance category in our timekeeping area for people that can be off work and get workplace violence pay. We're continuing to evaluate that, but there's certain criteria. So we've had to kind of refine it and put some more stringent controls on it over time. But it does help us calculate time off work related to these incidences. And we've also worked with our human resources partners to look at people that are resigning as a result of violence. Typically, they may not necessarily tell you that in the beginning of their exit survey, but in a 90-day out survey after they've been gone, they will tell you that, and they provide us that information back too, and the locations as to why they left. So this is some of the data from the beginning of the calls by year. But when you look at the contacts, it definitely shows a difference when you look at 2022 and 2023, which are actually related to a lot of it's related to the violence. And then looking at how we support, so lavender carts, we have 3 of them. We've created a meditation room. We've identified stress balls and just things that impact every single sense that we can roll out to a unit when they can't go to a meditation room, which opened a year ago in February. And we only have a meditation room right now at the main hospital, and we just opened one in the correctional health setting in the jail. So these roll out, they have items, but we also go through, just the usual, an encounter mode, but there's teas in there's candies, there's crayons to be able to color, things that can kind of take their mind away from the stressful environments that they're in. And then we also, for those that were involved in violence, we've created supportive care packages, and we have special cards that say we're wrapping you in support. And we identify things to be able to put in them. Again, one of these is the alarm. I'm not advertising this, but one is the personal alarm that we were able to get for our employees through the workforce studies, which we now give to every employee in new employee orientation as we present in orientation to tell them all the things that we're doing. And then again, our meditation room on the in the hospital. So I'm a healthcare risk manager, so I actually wanted to put in here what, when you look at the domains of healthcare risk management, how this would impact you. So from an operations point of view, if we're not managing it, then nobody is. So it will have an impact, whether it's your human capital component, which there is extremely high impact, or even just in operations, if people are not functioning the way that they should. Clinical and patient safety, if you're taking care of your folks, you're going to see less errors that are happening. So that transcends to a more positive working environment and relationship. And then again, as I mentioned, human capital. We can't speak enough about keeping our, we've talked a lot about social determinants more recently related to patients that came out of the pandemic. We need to do the same for our employees. How do we know that a perpetrator is not living in the same high-risk zip code as the victim, who's our employee? Information technology is your friend here, and they've been able to help us with many of the alerts that we've put in the medical records that I haven't really referenced here. We do have behavioral alerts. We also have termination screens when a patient has been terminated from the system. Should they show up through the ED, which they are allowed to do, we let people know that they've been terminated and these are the next steps to take. In addition, legal and regulatory, we have had moderate impact there, but certainly as we get into PTSD and employment claims down the road for injuries, that may become more of a high risk category. And then with a reputation, it's extremely high. We're all fighting for the same number of resources, and we want to be the best that we can be in Dallas County, but we also want to be able to share with our colleagues too of some of the best practices, but not just share, but also learn from them too. And so we have a retreat. We need to take care of our caregivers who take care of our caregivers. So we actually have a retreat scheduled for this Friday, which is going to be a spa day for them. It's not truly going to a spa, but we're bringing spa-like items to them. And we've had different types of themes like Ignite Your Spark and those kind of things where we've had to really know that we've had to lean in order to keep them fresh and keep them ready to go and armed with more energy to keep our employees at the rate it's a mental health rate that we want them to be. So I am going to turn this over to Helen to see if there's other questions or what the next steps would be.
Thank you so much, Karen. The fantastic presentation today. Truly walking us through your systematic approach to workforce well-being. This has just been fantastic. I'm going to open it up to anyone in our audience who has any questions for Karen. You can use the chat. You're welcome to unmute yourself. Does anyone have any questions for our speaker? Say, while folks are thinking specifically for our audience, thanks for putting that QI risk management lens on the ROI there at the end. I know that that's a real piece for our folks when they're trying to, get leadership buy-in and to start programs like this. I just really appreciate that.
Oh, you're welcome.
We have Emily saying, thanks for sharing your journey. Nancy saying, such impressive work. Thank you for sharing. Absolutely. Josh saying, excellent presentation. Thank you. Yeah, absolutely. You've done so much work at the state level, the system level, really going in with that approach. Thank you so much for sharing. Absolutely. A very impactful talk, just sort of showing us and the data as well. Thank you for sharing that. We know that reporting structures and strategies to get that data is sometimes lacking at the systems level. And so your approach to collecting the data and then just really showing us what you can do based on that information, once it's collected. More enjoy the breadth and approach to your topic. Very impressive. Appreciate you sharing. Absolutely.
Yeah, there's so much more we want to be able to do too, looking at proactive things, but, we're happy to share. We definitely want to learn from other folks. Being able to, we want to be able to do research on some of the work that we're doing. I have been involved working with, our organization's been involved working with, our Parkland Center for Community Innovations, and we've looked at AI and have been working on some AI opportunities too. So there's definitely more things that we continue to lean in, but it's gratifying work. It is hard work. I'm not going to lie.
A lot of gratitude here for sharing, yeah. Any feedback from, so I know you have a spa day coming up this Friday and, you know, the lavender carts and sharing things like that. Have you heard feedback from staff, you know, about their experience with those, or that they appreciate, you know, being able to participate in those proactive, you know, attempts at workplace well-being?
Yeah, I mean, the lavender carts have been a huge hit, and we actually are grounding intentionally every Monday in the behavioral health areas just because they're so inundated. We're trying to figure out how to capture and get some into the clinic settings. That's one of our goals, is to have them in some of the larger clinics where we know that we have some of the champions as well as supporters out there too. And in the jail. They are, you know, we stock them out of our space, with, you know, the candies and the supplies, but we're willing to do that. It seems to make a difference. And in the meditation room, we actually have a QR code as to what stress they were level they were at when they came in. And then when they leave, we ask them to take it again to see if it has gone in. And some days I just go in there. They're not allowed to eat lunch in there. They're not allowed to sleep. It's not a place for sleeping or eating lunch. But I will go in there to kind of see how it's going, but also just to kind of do the same thing and just kind of decompress for a few minutes before I'm running to another meeting.
We got Nancy's asking, she's curious to know about retention rate for staff involved in violence. Do many stay working, or do they leave the system or healthcare altogether? Oh, great question. I know that you are showing the data around, you know, those folks that had received a letter around, you know, aggressive behavior. Do you have any stats on retention for folks that have experienced violence?
You know, it's a great question. We don't have specifics, but I'll tell you, because we offer sparks with each one, we offer to take, you know, for them to go to the emergency department. Many of them don't take us up on that. We haven't had a whole lot of folks resigning as a result. We've had people raise the issue of concern, like if they've seen a weapon on somebody that has really escalated them, and they know that they're a single mom that has 4 children at home and doesn't want to be near something like that. We've worked with HR to actually get them into different positions where they would have less of an interaction like that, and to kind of salvage them within the organization when they don't really want to leave, but they would have, you know, they wouldn't have a choice otherwise. So we've really kind of worked, like I said, arm in arm, hand in hand, to support people and to get them into the right space. But we haven't seen a lot of people resigning as a result. In fact, you see our numbers going up because we're continuing to educate people on the necessity of reporting. We have a hotline for reporting. We have an email to report to give us the specifics. If you can't put it in, realize sometimes these are time consuming and you've already worked a 12-hour plus shift, we will put it in for you. So we're taking those extras that sometimes people just don't have, you know, any more space or you know, reserve to be able to do one more thing. So we are seeing that improve, and we are seeing the number of verbal assaults, because people weren't reporting verbals at all. They were just assuming it's part of their job, when in essence it is not. You know, treat me with respect, I'll do the same for you. And we have seen those numbers increase dramatically since we've been educating people on it.
Some just removing burdens around reporting and really making people feel like, you know, their human aspects of their experience are important. It's not just part of the job. So yeah, Nancy says, thank you. Kudos to you and the team. Absolutely.
Yeah. Yeah. I mean, I'm like I said, I'm just the megaphone. I, you know, put some of the ideas out there, but they make them happen. So, I'm happy to be a part and a leader in this space.
Absolutely.
And you can
Questions
certainly,
for-
you can certainly reach out if you want to via email or phone, either way. I'll be happy to talk with you guys.
Thank you so much, Karen. Absolutely.
You're
We
welcome.
just go forward a couple of slides. I'll just remind
Mhm.
everybody about our next session.
Oops.
Oops. There we go. Thank you so much. So our next session is actually on June 26th, where we're going to be hearing from a critical access hospital. Presentation called Yes, It Can Happen Here, Lessons Learned in Violence Prevention from a Critical Access Hospital in Montana. As you'll note, we are not having our session next week in recognition of Juneteenth, next Wednesday. And so we're just going to go right ahead with our following session on the 26th. I'll send along a formal cancellation for that in the coming days. But final thank you. We are absolutely thrilled to have you, Karen. This is just fantastic. What an eye-opening talk about your work at the leadership level, how you've really worked to, systematize well-being and change people's minds and change a whole system's minds and ways that they behave in this space. It is just fantastic. Thank you so much for your time.
You're very welcome. Thank you.
Absolutely. Have a great rest of your day, everybody. Thank you for joining us, and we'll see you again soon. Thank you.
Thank you.